Assalamu alaikum. Welcome to Bexidoc Talk podcast, Obs and Gynae. Let us first know what podcast means. It means personal on-demand broadcast. A podcast can have many purposes, but the main one is to entertain its audience. Podcast listeners might have one of several reasons to subscribe to a podcast, such as to hear updates and breakdowns of current events. So from Bangladesh perspective, podcast is a very new concept. It can be a pioneer project. It can set the milestone in terms of medical education. Today, the Bexidoc Talk podcast, Obs and Gynae, is packed with the information all about gestational diabetes mellitus. The short and informative voice recording, produced by the obstetricians of Burdham General Hospital 2, provides information about gestational diabetes. We are talking about what exactly gestational diabetes is, how common it is, how it's diagnosed, and how it's treated. We'll also cover some of the side effects of gestational diabetes mellitus, that is GDM, that can impact mother and the newborn, and why we need to pay extra attention to mother's own health in the postpartum period. According to World Health Organization Guideline 2014, gestational diabetes mellitus, that is GDM, is any glucose intolerance with onset or first recognized during pregnancy. It is usually diagnosed during 24 and 28 weeks gestation. Women with GDM do not have to have had diabetes before pregnancy and will usually recover post-pregnancy. According to International Diabetes Federation, that is IDF, Diabetes Atlas, 10th edition 2021, prevalence of gestational diabetes mellitus in Bangladesh is about 18.5% and globally it is 16.7%. This rising prevalence of gestational diabetes mellitus is associated with higher maternal and neonatal morbidity. It carries additional long-term health consequences for the mother and her offspring. The additional burden placed on the healthcare system by increasing cases of GDM requires consideration of diagnostic approaches and currently used treatment strategies. Today, I'm going to be the moderator of all the episodes. I'm Dr. Noshaba Tarannum Mahatab, working as the Assistant Professor at the Department of Obstetrics and Gynecology at Burdham General Hospital 2 and Ibrahim Medical College. As I mentioned earlier, we are going to talk all about gestational diabetes mellitus. There are 5 episodes to cover all the aspects of GDM. The 5 episodes are namely Episode 1, Pre-conceptual counseling for control of gestational diabetes mellitus during pregnancy. Episode 2, aim and necessity of glycemic control during pregnancy. Episode 3, principles of general management of gestational diabetes mellitus during pregnancy. Episode 4, pharmacological management of gestational diabetes mellitus. And Episode 5, postpartum care of gestational diabetes mellitus for mother and newborn. Now we are going to start the first episode of Bexidoc Talk podcast, Obs and Gynae, about gestational diabetes mellitus. Our first episode is about pre-conceptual counseling for control of gestational diabetes mellitus during pregnancy. Our first speaker is our Professor T.A. Choudhury sir. Sir will be with us throughout the whole session. Professor T.A. Choudhury sir has been teaching undergraduate and postgraduate students for the past 50 years, mostly postgraduate students. Most of his students are now professors at different medical colleges throughout Bangladesh. He is still continuing with his teaching activities. Sir at present is working as the honorary professor at Obs and Gynae Department of Burdham General Hospital 2 and Ibrahim Medical College. Sir, welcome to this episode.
Thank you.
Sir, would you like to briefly let us know about the pre-conceptual counseling for the control of gestational diabetes mellitus?
Thank you, Dr. Noshaba. Today we are going to talk about the preconceptional advice, advice to be given to the patients who want to take a pregnancy. Now, how you identify many of these patients actually do not know before pregnancy that they are diabetic. Some are non-diabetic at the beginning of pregnancy, but because of the hormonal effects of pregnancy, their glucose tolerance becomes impaired and ultimately they become frank diabetic towards the later part of pregnancy, generally after 28 weeks of pregnancy. So, these are the genuine cases of gestational diabetes mellitus. But when the patients come late, it is not possible to distinguish whether they were diabetic from before pregnancy or the diabetic has developed as a result of the stress of pregnancy. So, the definition, as you all know, is quite liberal. That means, if diabetes is detected for the first time during pregnancy, it is called gestational diabetes mellitus. At that stage, we really do not know whether they were diabetic from the very beginning or the diabetes has developed as a result of the stress of pregnancy. It will become apparent only at a later stage when the pregnancy is over and 6 weeks after postpartum, when the patient still shows a blood sugar level which is in the diabetic range, we will presume that this patient was diabetic from the very beginning. And if it is genuine GDM, what will happen that in most cases the blood sugar level will come back to normal after the pregnancy is over, and it will remain normal till she gets another stress of pregnancy. So, gestational diabetes pregnancy has got a tendency to recur, and that should be remembered, and that is why in case of preconceptional counseling of this patient, the past history, whether she had impaired glucose tolerance or genuine diabetic in the previous pregnancy, this history is extremely important. That will decide us, apart from a group of patients who are very likely to develop diabetes in the next pregnancy. So, generally what happens, actually the patient, we have a group of patients, a particular type of patients who are most likely to have diabetes or have gestational diabetes during pregnancy, and these are the group which requires further advice and before they take up their next pregnancy. First is obese patient. You know, obese patient who has body weight is more than 20 square meter per square, they are generally at a more risk of developing diabetes during pregnancy. So, obesity is a risk factor which by proper counseling you can make some changes. The patient may wait. If taking pregnancy is not urgent, they can reduce some body weight before they try their pregnancy, and that will be of immense help during her next pregnancy. The patient who had previous intrauterine death of the fetus or premature labor or baby died in the neonatal period, they are also a suspect group, and they should also be counseled and if necessary investigated before you advise them to take another pregnancy. Sometimes we ask the weight of the last baby. If the baby's weight is more than 3.5 kg, these are overweight babies, or they may be frankly macrosomic, when their baby's body weight is more than 4 kg. Now, these are the group of patients who are likely to be cases of GDM. On the other hand, a long-standing diabetic may have also a baby which is less than normal body weight. That means the growth is less and this difference is possibly due to changes in the blood vessels which occur in the uterus as age advances. So, long standing diabetes generally reduces the blood flow in the later part of pregnancy and produces a low birth weight baby, whereas early GDM in young age actually increases the blood flow, and because of the metabolic changes the baby weight is increased. So, family history is important. That means immediate family members such as brothers and sisters, parents, or second degree relatives even, if they have got a definite diagnosed cases of GDM, the patient presently who presents for advice, she may also be a case of overt or actually even sometimes in some cases a suspected case of GDM. So, these are the type of cases who will require special advice. So, what advice we should give to them? Preconceptional. So, first important is that if the patient comes to me before advice to take whether she can take another pregnancy. So, the first important thing is to decide definitely whether she is a case of glucose intolerance or a case of genuine diabetes mellitus. Nowadays, it is comparatively easy. You can do an easily glucose tolerance test, or if you do not do that, even a random blood sugar test will give you some idea that this patient may develop diabetes during her pregnancy. And actually, this is quite common in this country. About maybe 15 to 20% of the patients ultimately will be complicated by diabetes. So, it is very important and to assess the blood sugar level. The importance of blood sugar testing, particularly glucose tolerance test, is to some extent to give a glucose load which will simulate the load that they will face during pregnancy, and to find out whether they can tolerate that excessive glucose load. And some of them will not be, the blood sugar will not cross the diabetic level, they will remain below the diabetes level by definition, but still they may be intolerant to the normal glucose metabolism and can show some incompetence in dealing with any excessive glucose overload. So, first important thing is to do a genuine glucose tolerance test, and sometimes if the patient every test is available, a hemoglobin A1C test is also useful, because that will show her average blood glucose over a period of several months rather than days. So, first we ensure that this patient has got glucose tolerance or a patient is genuine cases of diabetes. And before they take pregnancy, one important thing is that optimum body weight is important. So, if the pregnancy is not urgently required, patient is overweight, as we have said before, the first advice will be to lose body weight, so that she gets the optimum body weight and her health is in the optimum condition to take this pregnancy and continue the pregnancy safely. So, this is the first thing. Second important thing, we always advise to this patient that these patients must have a very close antenatal checkup. Sometimes a difference of 4 weeks as we examine the patient from 20 weeks onwards, or even a difference of 2 weeks can make quite a bit of difference in the growth of the fetus and well-being of the fetus. So in some cases, this patient may have to come for more antenatal checkup, and that patient should be warned that if she takes this pregnancy and wants to carry this pregnancy safely up to term, she must be continuously under medical supervision, and if necessary, much more frequently than the other patients who are having regular antenatal checkup without diabetes. So this is second important thing. Third important thing is dietary intervention is important. In pregnancy, it becomes a little more difficult because if the patient is overweight, you want to control her diet to some extent, but at the same time, you should also remember that the baby requires the nutrition from the mother. And if you restrict the diet too much, the baby may ultimately suffer from deficiency of essential nutrition, and you may get a low birth weight baby, which we do not like to have. A baby should have an optimum birth weight in order to have a good chance of survival and developing normally, physically and psychologically. So here one has to be very careful about dieting restriction, and if necessary, help from a dietitian is always useful. So if you go to any center where diabetic pregnant patients are being taken care of, generally there is a dietitian also in the team, and he or she can give proper advice regarding the diet. In case of diet, I think I will emphasize more on the trace elements, vitamins and minerals. These are quite important, that if there is deficiency of these minerals, they can have an adverse effect. Particularly in this connection, we can talk about the folic acid. Folic acid is one essential vitamin which generally prevents congenital anomalies of the babies. And as you all know, the diabetic is a condition in which the patient is likely to have a congenital abnormal baby if the blood sugar is not controlled during the early pregnancy. So that is why we get more cases of congenital malformation of the baby if the patient is already diabetic. In case of GDM, pure GDM, where the patient has normoglycemia before pregnancy, the hyperglycemia occurs toward the later part of pregnancy. At that time, the risk of congenital malformation is significantly reduced. So, in order to prevent the congenital malformation, you should first of all assess if the patient has got an impaired glucose tolerance, and that must be controlled. That must be controlled before she takes pregnancy in order to prevent the risk of congenital malformation. And on the addition, we also ensure that there is no lack of essential vitamins and folic acid, which are also important for the prevention of congenital malformation. So, the dietary intervention is important. And third important thing is that to insist on the patient that if the blood sugar is not controlled by usual lifestyle changes, such as say walking, changing the character of diet and so on, drug therapy may be required, and she must be warned that in pregnancy sometimes the oral hypoglycemic agents may not be suitable, and the patient may be advised to take insulin. And insulin is an expensive drug, and she must be physically and mentally prepared to spend that amount of money if she wants to take a pregnancy. So this financial consideration also I think important, and particularly in those patients who have already got 1 or 2 babies and contemplating to take another one. They should decide first of all whether they can comply with the lifestyle changes which will be required in diabetic pregnancy and the additional expenses which may be incurred during the care of diabetic pregnancy, during pregnancy, labor and afterwards. So these are all counseling I think is important. The patient should understand that if she wants to take a pregnancy, what are her liabilities. And in this counseling I always advise that the husband should also be present, because this is a matter which involves both. And sometimes if we counsel the woman only, the husband may not be aware about the gravity of the situation and the possible consequences. So this consultation should be a joint consultation with the patient and her husband, and if necessary any other guardian who wants to be present. So after we have counseled the patient properly, and if there is a glucose intolerance found, it is corrected. If she is overweight, the body weight is reduced to near normal. She does not show any deficiency of any nutrient, only then we will advise her to take her pregnancy. An important thing is that once she becomes pregnant, it is important that she is under medical supervision from the very beginning. Diabetes generally, even with GDM, will make its appearance toward the later part of pregnancy, and if she is diabetic, it will become more severe as the stress of pregnancy increases. So later part of the pregnancy is more important, because we have to monitor the growth of the baby, we have to control her blood sugar as good as we can in order to prevent complication. And these patients are also liable to have infective complications of pregnancy, such as vaginal infection, urinary tract infection and so on. So all these should be explained to the patients in detail, and if she has got any question, that should be answered properly, and only then we will advise her to take her pregnancy, taking into consideration the fact that she has to be within the reach of a hospital where care for diabetic pregnant women is available, and she must be prepared to take multiple visits to the hospital in order to carry on her pregnancy safely and deliver a safe and healthy baby. So counseling is extremely important. No diabetic patient or GDM patient should start her pregnancy without a prior counseling. But unfortunately, many cases are not diagnosed before, and they do not come for counseling early in the pregnancy. But we must insist that a patient, if she had a GDM in previous pregnancy, must have a pre-pregnancy counseling before she tries her next pregnancy.
Sir, you have already mentioned about most of the risk factors associated with the development of gestational diabetes mellitus. Would you like to give emphasis about patients with polycystic ovarian syndrome? Are they prone to develop GDM?
Oh, thank you very much. You know, polycystic ovary is now being diagnosed more frequently, and actually there is an actual increase in the incidence of polycystic ovaries nowadays because of our lifestyle and also dietary habit. Now, polycystic ovary is a multi-organ disorder mostly affecting the hormonal system of the body, and that is why this imbalance of hormone produces both infertility and complications during pregnancy if they happen to become pregnant. So nowadays there are many patients who will come for the treatment of infertility with PCO, and some of them will obviously become pregnant. Now, one of the important things is that these patients are excessively liable to develop GDM as pregnancy advances due to their hormonal milieu, in which there may be improper balance of the hormones. So, many of these patients actually become pregnant after taking metformin, and which reduces the insulin resistance. And now the question arises whether they should continue this metformin, because this is a small molecule which can cross the placenta, and there was once a fear that it may produce some congenital abnormalities in the babies. But now this has been amply proved that it is not a teratogenic drug. Now, on the other hand, we have found that if metformin is withdrawn quickly, then before the endocrine balance is restored, there may be an increased risk of even miscarriage. So, there is no controversy nowadays that metformin should be continued up to 12 or even up to 16 weeks if a PCO patient becomes pregnant and she is already on metformin. Whether this can be continued further, now that is not still very clear. There are several studies where metformin has been given throughout the whole pregnancy in order to control type 2 diabetes if the patient has developed GDM type of blood sugar level, and the pregnancy has resulted in normal babies and an uncomplicated pregnancy. But traditionally what happens, we rely more on insulin for the day-to-day control of blood sugar, even the patient, whether the patient is PCO or non-PCO. So, many patients now, many physicians now discontinue metformin after the first 4 weeks, 16 weeks or so, and because metformin cannot control blood sugar from the hour to hour level as insulin can. That means insulin can do a more meticulous control of blood sugar than metformin. So, they have got more confidence on insulin, and they change metformin for insulin and continue this according to the schedule, as you will hear later on. But as I have said before, that insulin is a drug which up till now has not been shown to have any teratogenic effect, though it crosses the placenta and well tolerated by the patient, and in many cases maintains the blood sugar at a level which is safe for a pregnancy with GDM if the patient had previous PCO, and whether it can be given in a patient who did not have PCO and was not having metformin from the very beginning. There is some controversy, but still we prefer that if the patient is not PCO patient, we can control the blood sugar better by insulin, and in pregnancy meticulous control is very important. So, metformin has got its limitation, that should be understood, but it is a cheap, safe drug which can be used in selected cases and particularly in PCO cases, and must be given for first 16 weeks of pregnancy.
Sir, you have mentioned about the role of folic acid. Would you kindly let us know what duration of folic acid should be given during the preconception period, and what would be the dose?
Thank you. Essential for the formation of the neural system, the nervous system of the fetus. Now, in those fetus who suffer from deficiency of folic acid, there is a high risk of open neural tube defects like anencephaly and other problems. And for this reason, we advise that the patients, all patients during early pregnancy should have a folic acid supplementation, because we cannot ensure whether they will get appropriate amount of folic acid during their pregnancy, because folic acid is a heat labile vitamin, and if the food is cooked too much, the folic acid may be destroyed. So, in case of GDM patients, it is much more important to give the patients folic acid and ensure that the patient is getting the proper amount. So, as you have said, then pre-conceptual counseling, we advise the patient to start taking folic acid as soon as they decide to try for pregnancy. And once they become pregnant, the folic acid should be continued at least for the first trimester, that means first 12 weeks. The dose, normally the normal daily requirement is not very high. It may be even 0.4 milligram. But what happens, we generally such a small dose is not available, and folic acid is a safe drug. The lowest dose tablet you get is 5 milligram. So, 5 milligram tablet, one tablet every day, starting from the time the couple will try for pregnancy up to the first 12 week of pregnancy is the advice. So, folic acid, if somebody will ask you if you continue the folic acid longer, is there any bad effect or adverse effect? Actually, there is no adverse effect as such, but mostly will not advise a drug which is not further required during pregnancy. But remember, in this country there are many women who are anemic, and folic acid is required also for the synthesis of hemoglobin. So, in some cases we may continue the folic acid as a result of treatment for anemia rather than prevention of congenital anomalies. A general rule is that folic acid should be started as soon as the patient or the couple decides to take a pregnancy, and should be continued throughout the first trimester at least up to 12 weeks, and then it may or may not be continued according to requirement.
Podcast gives us the freedom to listen to what we want and when we want and how we want. Practitioners can tune in on their preferable time as their time is limited. In addition, multitasking and podcast can also go together, as podcasts are easy to listen to while practitioner is doing other things. Gestational diabetes mellitus is a very common concept and is easily understandable for all. As the global rate is going up in case of gestational diabetes mellitus, it is becoming one of the leading causes of maternal and neonatal morbidity and mortality. Listening to Bexidoc Talk podcast, Obs and Gynae, about gestational diabetes mellitus will gain a new perspective. With this hope, I am Dr. Naushaba Taranum Mahatab signing off.